Hello everyone. Today we'll discuss about Down syndrome. So starting off with its incidence, it occurs in 1 in 733 children. Going on to its genetics, everybody knows Down syndrome is trisomy 21. There will be 3 copies of this chromosome number 21. This origin of this third copy. So origin of the supernumerary chromosome 21 is mostly maternal in origin. In 97% of the children, it is mostly maternal. Okay. In maternal case, it occurs due to non-disjunction during meiosis. It occurs as a result of non-disjunction during meiosis. Okay, that is error during a meiosis. In 4% of the cases, it occurs as a result of translocation. So how does this translocation occur? This occurs as a fusion at the centromere between the chromosomes such as 13, 14, 21, 22 and 15. So it is 13, 14, 15, 21 and 22. So when you find the child to have the features of Down syndrome, next you will be doing a chromosomal analysis. In chromosomal, that is karyotyping. So in chromosomal analysis, when translocation is identified, so when a translocation is identified in chromosomal analysis, of the child, next you have to do parental chromosomal studies. So why we have to do parental chromosome studies is to find out the recurrence risk. Okay, that is to find the recurrence risk or chance of next child having the Down syndrome. So when you do a parental chromosome studies and find to have the mother to be the carrier, okay, when you find the mother to be as a carrier, there will be a recurrence risk of 15%. So the next child to have the features of Down syndrome will be 15%. Or when you find the paternal, that is a father to be a carrier of this translocation gene, there will be a 1% chance of the recurrence risk. In a translocation, if the translocation is between chromosome number 21 and 21, the recurrence risk is 100%. There will be a 100% chance of a chromosomally abnormal child. Okay, next, this is the second cause of the genetics for Down syndrome to occur. Third reason, that is 1% of reason can occur due to mosaics. Then mosaics, if the chromosomal analysis study is found to have mosaics, the child phenotype will be a milder form. That is mental retardation or developmental delay, everything will be a milder form in a child with mosaics compared to a child with translocation or non-disjunction during meiosis. Okay, so this is about the genetics. Next we'll go on to its clinical features. In clinical features, we'll start from head to toe. In CNS, the child will have developmental delay, microcephaly. The child will have delayed closure of fontanelles. The child can have 3 fontanelle and he will have flat occiput. Next, in face, the child will have a flat face. Coming to its features in the eyes, the child will have a upward slant of the palpebral fissure. So there will be an upward slant of palpebral fissure, this epicanthal fold. Next, this brush field spots. These brush field spots are the spots that occurs in the periphery of the iris. Whitish pulse that is occurring in the periphery of iris, it occurs due to the collection of the stroma. Next, a child will have flat nasal bridge. In mouth, the child will have a protruding tongue, small mouth or open mouth. And in ears, the child will have a small dysplastic ears. In neck, coming to the neck, the child will have a short neck. These are the facial features of a child with a Down syndrome. Next, going on to its extremities, the child will have a single transverse palmar crease, which is called as simian crease. The child will have short metacarpal, short fifth digit, along with that there will be inward turning of the digit, so that is called as clinodactyly. There will be a wide gap between the first and the second toe, which is called as sandal gap. So these are the features of a child with Down syndromes in extremities. Coming on to its cardiological features, first, the child most commonly present with endocardial cushion defect. The child can have VSD, ASD, PDA, and aberrant subclavian artery. So this question they can ask you even in the Viva sessions. What are the cardiological features of a child with Down syndrome? So then you can mention endocardial cushion defect, VSD, ASD, PDA, and aberrant subclavian artery. In GI, the child can have duodenal atresia. So compared to the normal population, the chance of occurrence of these duodenal atresia, next annular pancreas, tracheoesophageal fistula, Hirschsprung's disease, and imperforate anus will be higher in a child with Down syndrome compared to a normal population. Next is annular pancreas. Third is tracheoesophageal fistula. Fourth, Hirschsprung's disease. And fifth is imperforate anus. Coming on to its musculoskeletal features, the child will be a hypotonic child first, and there will be joint hyperflexibility, and the short metacarpal, short fifth digit, clinodactyly, everything will come under musculoskeletal features. And the last one will be pelvic dysplasia. This also comes under musculoskeletal features of child with Down syndrome. Next, we will talk about its Hall's criteria. This is also one of your Viva question. Hall's criteria of a Down syndrome. What are the features? As I have mentioned already in one of my shots, I'll write it here also. The features 4 in face. Remember like that, 4 in face. So the features are, first one will be flat face. Second is upward slant of palpebral fissure. Third will be dysplastic ears. Fourth is short neck. Okay. Next, 3 in tone. 3 in tone is, so this is F. 4 in face, 3 T. 3 in tone. One is hypotonia. Second is in newborn baby, you will elicit a poor Moro reflex. Third is joint hyperflexibility. Okay, this is 3 in tone. Next, there will be 2 in hand. 2 in hand is, first is the single transverse palmar crease, that is simian crease. Second is clinodactyly. And the last and final 10th feature is one in hip, that is pelvic dysplasia. So these are the 10 features that you have to tell in Hall's criteria for Down syndrome. Okay, next we'll go on towards prenatal screening. So according to the IAP recommendations, prenatal screening should be offered to all the pregnant women. So it is done to all the pregnant women irrespective of their age, family history or ethnicity. It should be done in all the pregnant women. In prenatal screening, starting off with the test during the first trimester. First is the combined test. So in combined test, this includes maternal age. Next is nuchal translucency. Third is double marker test. In Viva, they can ask this combined test, triple marker test and quadruple test also, and double marker test. So in double marker test, what all it includes? This includes serum free beta HCG and pregnancy associated plasma protein A. This both comes under this double marker test. So in first trimester in combined test, you will include maternal age, nuchal translucency and the double marker test. Second is combined test, that is these three tests. Along with that, you will be seeing the ultrasound marker. In ultrasound marker, it includes, this includes nasal bone or its tricuspid flow or the ductus venous flow. Okay, this comes under the first trimester screening. Next, in second trimester screening, that is done between 15 to 22 weeks. First one is triple marker test. In triple marker test, it includes maternal age plus serum free beta HCG, alpha fetoprotein and unconjugated estriol. Okay, this has a detection rate. I'll write the detection rate here. This has a detection rate of around 65 to 70%. Okay, next in quadruple test, so it includes this triple test plus there will be another one, that is inhibin A. They have a detection rate of around 70 to 75%. Okay, detection rate for the Down syndrome. So these are the prenatal screening. Next, we'll go on to its management according to its IAP recommendation. First is the growth monitoring. For growth monitoring, you will be requiring the height, length and the weight and head circumference of the child should be regularly monitored, and this should be plotted in a growth specific, that is Down syndrome specific. It should be plotted in a Down syndrome specific chart that is available, available in CDC. Okay, it is according to Down syndrome specific growth chart. You have to mark the weight, height or length and head circumference. Okay, next is cardiac monitoring. In cardiac monitoring, there is a high prevalence of congenital heart disease in children in Down syndrome. So it is, the prevalence is about, so prevalence of congenital heart disease in children with Down syndrome is 40 to 60%. So there should be a routine echo. So there should be a routine echo screening should be done for a child with features of Down syndrome at birth. So routine echo screening should be done at birth and cardiac status should be established by 6 weeks. So this should be established by 6 weeks of age. So at birth you will do echo, and at 6 weeks you will confirm the diagnosis. So once you find a child to have some cardiac congenital defect, there should not be any delay in correction. So it should be done as you do for the child with the normal child, as you do for a child with no Down syndrome. Okay, there should not be any delay in the correction of the defect. So management should be done on the same line as the children with the Down syndrome. Okay, next is the endocrine and the thyroid status. So child that is Down syndrome child can have about 25 to 50% chance of having this thyroid problems. So first, congenital hypothyroidism is not always picked up in newborn screening. So why you will do a newborn screening also, but the repeat screening. So the repeat screening should be done at 6 months, and again you repeat the screening at 1 year of age. Then it is repeated yearly. Then it is repeated yearly till life. Okay. Second, what is the current recommendation for subclinical hypothyroidism? So current recommendation for subclinical hypothyroidism is to treat only when TSH remains more than 10 milli international units per ml. So you have to treat only when the TSH remains more than 10 milli international units per ml, or if there are features, or if there are clinical features or clinical symptoms of hypothyroidism or goiter or autoimmune thyroiditis. So when you find these features, then you can treat the subclinical hypothyroidism. Next, fourth one, in hearing issues. The child can have 50% of the child with the Down syndrome will have hearing impairment. This hearing impairment can be unilateral or bilateral. One, it can be conductive hearing loss, or it can be a sensorineural hearing loss, or it can be a mixed one. The child with Down syndrome, they will present, most often they will present with otitis media with effusion. Okay, this otitis media with effusion, when the recurrence risk of this is high, the child will automatically go to a conductive hearing loss. So when a child have a high recurrence risk of this otitis media with effusion, then you will do a grommet insertion for this child. If even after the grommet insertion the child is having this recurrence risk, then you will do along with the adenoidectomy. Okay, so child with the Down syndrome having the features of otitis media with effusion, you do a grommet insertion with adenoidectomy. Next, so first you will do a neonatal screening. All the newborns that is being admitted in NICU, you will do a hearing assessment. Next will be the full audiological assessment. Full audiological assessment is done between 6 to 10 months. Okay. Next is the review. Full audiological review is done at 18 months of age. Next, this audiological review is repeated yearly till the child is 5 years. Okay, till 5 years of age. Then this can be repeated 2 yearly once. This can be repeated 2 yearly once for the life. This is about hearing issues in the Down syndrome. Next is ophthalmic problems. In ophthalmic problems, the child will present with refractory error. Next, strabismus. Fourth, the child can have keratoconus. Fourth, the child will have nasolacrimal duct obstruction. So this can even occur in a child without Down syndrome, but the chance of occurrence in Down syndrome will be high. So the recommendations according to IAP is eye examination is carried out at 4 to 6 weeks of age. Next is the ophthalmic review. Ophthalmic review is carried at age between 18 months to 2 years of age. Next review is at 4 years of age. Next is every 2 years once you will do this review throughout the life. This is about ophthalmic problems. Next is the oral issues. So recommendations according to IAP is first dental visit should be within 6 months of the first tooth eruption. So first dental visit is within 6 months of first tooth eruption. Next, thereafter it is carried out yearly till 5 years of age. Okay, there should be brushing twice a day with a soft brush, and fluoride toothpaste should be used in this oral health issues. Next is the hematological problems. The child will have high risk for AML, ALL, and 60% of the child will have polycythemia. Okay, and the child will present with transient abnormal myelopoiesis. The child can have transient abnormal myelopoiesis. Okay, so the recommendations is all the newborns with the Down syndrome should have newborns with the Down syndrome should have CBC and the peripheral smear. This should be repeated yearly till 5 years of age. This is about the hematological. Okay, in GI you have to inspect the child fully, thoroughly. The child should be inspected. Inspection of perineum for the anal patency. Next, inquire about the passage of meconium. So this is about the GA. Okay, so these are the main recommendations and the features and management of the child with the Down syndrome. I hope I have covered everything. I have left this around neuropsychiatric problems or behaviors in a child with Down syndrome. I'll give it as a PDF in our Telegram group. Thank you. Please like, share and subscribe our YouTube channel. Let's all learn pediatric together. Thank you. I'll share